So good afternoon, everyone, and welcome to our broker webinar series, Healthcare Reform and Legislation Updates. My name is Christina Zah, Director of Product Development, and I'm pleased to have as our guest speaker today Marlene Baca, Loveless Health Plan's Chief Programs Officer. Before we begin, I would like to remind all participants to please place their phones on mute by pressing that *6 on their phone keypads so that we may hear our presenters. If you have any questions during the presentation, please feel free to either use the question area of the webinar tool, or again, you can take your phone off mute by hitting *6 to pose your question. Additionally, there will be a time at the end of our presentation for any questions you may have. We thank you again for your participation, and at this time, I'll turn it over to Marlene. Welcome, Marlene.
Well, good afternoon, everyone. Marlene Bach. I'm the Chief Programs Officer, as Christina indicated. Just to give you some background of who I am, I've been with the organization in the insurance industry for 24 years, so very pleased to be able to talk to you today about healthcare reform. Here at Loveless, in my position, I am responsible for the Medicare line of business as well as the Medicaid line of business. And with that, I'm also responsible for healthcare reform. So when PPACA was first signed back in 2010, I was very, very happy that I was asked to actually lead the initiative for our organization. So when we think about healthcare reform, you will, as all of you are well aware, it definitely changed our organization. And what I want to do is just kind of go through the timeline and some of the things that actually took place in 2011, and then we will go into 2012, as well as talk a little bit about how it's really going to be changing in the year of 2014. So that is the intent of this presentation this afternoon. So just kind of a reminder of what occurred in 2011. Some of the provisions that took place was the health savings account, and essentially it was the distribution of the tax penalty. And you will see that the tax penalty on these HSA payments were not being able to be used for eligible expenses, and it did go from 10 to 20%. Additionally, which was definitely a major change for many individuals, the provision itself does not allow any individuals to cover eligible dependents for that HSA if that dependent is not listed on their income taxes. So that was very, very different than in the past, and very important for that particular provision, because those adult child dependents are just not going to qualify for being under that HSA payment. So a big change that took place in 2011. The second provision that we want to highlight is the medical loss ratio. As all of you are well aware, insurers have to meet a percentage based on all of the medical and pharmacy expenses that we pay for the members. And with the PPACA, essentially when you look at the requirement, each of the insurance companies, they have to be at least at an 85% medical loss ratio for large groups, and then 80% for small groups or the individual book of business. And when you think about what will occur if these insurance companies do not meet this particular minimum medical loss ratio, then essentially what's going to happen is an annual rebate will be paid to all of those members or policyholders once the claims and other medical services are paid for, of course. And all of you may have actually seen, Kaiser actually released a report about 2 weeks ago. And what they did announce across the United States is that there will be consumers across the U.S. that will be receiving about $1.3 billion in rebates. And when you really kind of dissect and really take it to the level of each of the markets as well as the individual market, taking that $1.3 billion, about $541 million will be given back to those consumers that belong to a large employer group. $377 million will be given to those consumers that are enrolled in the small market, and then $426 million will be given to the actual individual members that belong to an individual plan. So really taking into account that $1.3 billion, it's about 31% of consumers across the U.S. that will be receiving some type of a rebate. Now, when we really look into the details of what that rebate means, at the consumer level, the average rebate is about $127. And when you really look at the various states, our understanding is that Alaska is probably more at the higher range at about $305. And then seeing some states where they're paying nothing, but on the higher scale, it's about $200 in Mississippi. Now, what is interesting, of course, for us in our own state in New Mexico, we're really not going to be paying back as much. But I really think that really has to do with, one, we're already accustomed to that medical loss ratio requirement on the Medicaid line of business. So when you really think about all of the insurance carriers that currently are very active in New Mexico, we were already under that requirement with Medicaid, and Medicaid's requirement has been around for about 4 years. So thinking about the big players here, I know Loveless, we are not in a position where we're needing to pay any dollars back to our members because our medical loss ratio is actually above of what the feds require. So I'm sure we'll probably see some questions at the end of the session regarding medical loss ratios. When you look at the next page for eliminating the Medicare Part D coverage, we call it, of course, in the Medicare world, coverage gap, but it's also known as the donut hole. And what you will be seeing with the Medicare reforms is that the federal government essentially really wants to close the gap and kind of get rid of that coverage gap. And they're hoping that they will reduce that gap within the next many years. And by 2020, you will see very comprehensive prescription benefits for those Medicare beneficiaries. But in 2011, any of the Part D members that actually hit their coverage gap essentially got a $250 rebate. Now, it didn't matter how much they actually spent out of pocket. It was any individual that just actually hit that coverage gap. So with our organization, what is nice about Loveless is that we do offer here in New Mexico that coverage gap for generics, and then of course we cover the federal requirement where we do front the dollars for brand name drugs of 50% out of pocket, and then later on we do see a reimbursement from the prescription manufacturing companies. So that's what occurred last year with this particular provision, and as I indicated, by 2020 you will begin to see that that gap will definitely reduce. Another provision is over-the-counter drugs, and in fact Christina and I were talking about this, and here we read the law, we knew the provision was coming, and here I'm signing up for my flexible spending account and I completely forgot about this provision, so I'm going to have to start spending my dollars other places. But as of January of 2011, quite a bit of over-the-counter drugs and medicines will no longer be able to be part of the HRA, HSA, as well as the FSA. And it's even drugs like allergy, Tylenol, And the only way that you are able to get these particular over-the-counter drugs to be part of any of those spending accounts, you essentially would have to have your provider write a prescription. And I unfortunately did not have enough time, but there's definitely now some discussions about physicians saying it's a little bit overwhelming of writing all of these scripts for OTCs. And I just saw an article hit my email just a little bit ago. So it'll be interesting to hear how loud the doctors are going to be regarding this particular provision. Now for 2012, one of the areas that we definitely need to focus on as an insurance carriers around administrative standards. And essentially what you will be seeing in 2002 is that we really are going to have to begin to standardize some of the documents. And there's also going to be some new reporting requirements that are going to be going into effect. Now, the provision itself is one to encourage integrated health systems, and to really be successful with this particular provision, it really is all around the ACOs that you've been hearing about, PCM, H, and we'll talk about that shortly. Also, we're going to talk about the quality of care reporting, reducing paperwork, talk a little bit about the summary of benefits and coverage, and then lastly we will talk about the women's preventive services. But all of those provisions do go in effect this year in 2012. So when we really look at that integrated health system, PPACA's initiative was universal coverage, but it really was also about delivering quality outcomes. So by being able to deliver those quality outcomes, we as insurance companies are really going to have to start changing the behavior. And whether it is our member by incentives to change the behavior with them, but on the integrated health system, it really is how we are going to change the system on reimbursements to the providers that we contract with. So by doing that, we're going to have to start looking at our provider reimbursement very differently. So as you are all aware, the majority of our contracts here in New Mexico are really based on a fee-for-service level. So if a provider sees a patient, they're going to bill, and we're going to pay, of course, if it meets all of the criteria. The new way and the new direction that Loveless does support is that we need to engage our providers in a much different manner. So incentives such as perhaps a capitation, so paying providers at a PMPM basis, and they do deliver the services, but there's other incentives that we can actually be creative with. So let's just say that the patients that they serve and their medical loss ratio is actually below a target amount, why not share the profits with that provider group? That's one way of showing a different type of incentive plan that you can do with providers. Another way is to be able to incent the providers with very strong quality outcomes. So by paying a provider of making sure that we're not paying for any never event, which means that they are hospitalized, something unfortunate happens in the hospital, we're not going to reimbursement for that particular procedure. So there's many ways that you can go with the incentives, and I just want all of you to know that Loveless is definitely very excited, and we're trying to be very innovative, but of course look at our provider partners and get feedback from them as well before we actually start implementing that. And then of course the other way is with accountable care organizations, and that essentially is kind of taking various specialties as well as primary care, and looking at that as a way of being able to partner with the health plan to make sure that we're meeting the needs of all of those particular members. And then the last item I want to focus on with that integrated health system, because we've done this very well on our Loveless Health System side, where we went through a demonstration project with the federal government for Medicare fee-for-service beneficiaries, where we are bundling our payments. So the federal government had a contract with Loveless Health System. They pay a flat dollar amount, but what we do is then we contract with that orthopedic specialist. We have a contract directly with an anesthesiologist, and the bundled payment that CMS pays us is less. But the good news is that the outcome of the quality and the patient themselves are released, discharged earlier. They have a plan, episode of care that they follow to make sure that patient is walking when they should, and so on. So overall, everyone wins, the provider, the insurance company, as well as the patient. The next item I want to focus on is really on the quality of care reporting. And this currently is a provision that we unfortunately really don't have much guidelines on. They're currently developing rules on how we will be reporting to HHS on benefits and how we pay for the health care services. So of course this really is tied with that quality outcome, because the goal is to of course report and make sure that we are having those very positive outcomes for the members that we serve. But additionally, we also know that we are going to have to report on the case management, the care coordination that we have within Loveless, report on some chronic medical and disease management that we do, as well as the medication therapy that we have in place. So again, the intent is for quality outcomes. It really is aimed to reduce some of the hospital admissions, and of course ultimately to have that patient safety in all of our medical settings. So we are very happy to continue to wait on those particular rules to make sure that we're reporting good things from Loveless. The other provision is around administrative cost and reducing paperwork. And one of the areas is going to be around the billing practices and making sure that everyone is consistent, standard, and we have a uniform way of being able to pay those particular bills. So as we're moving forward with ICD-9 transitioning over to ICD-10, we as an organization are feeling very good about our implementation plan, and even though that HHS has delayed the implementation of ICD-10, we continue to move forward and work very hard to make sure that all of it is in place. And we're also considering to adopt a way for us to be able to help the providers that have small offices, where they're going to be a little bit more challenged with dealing with much more CPT codes with ICD-10 versus what we currently have today with ICD-9. But the end result is going to be less administrative costs, because the intent is going to be less paperwork as well as less medical errors, as well as billing practices altogether. The next part that we really need to cover is all around the Summary Benefits and Coverage document. It's also being called SBC, and this is part of the PPACA, mandated for all health insurance to essentially issue the same summary coverage document to all potential as well as their current clientele that they serve. And some of you, if you are accustomed to working in the Medicare line of business, we actually had this introduced in 2006 when CMS felt that seniors were getting a little bit too confused with too many health plans, the way they presented their plans. So they did issue the standardization in that line of business many years ago. So essentially it is very similar concept to what we're going to be seeing here in the commercial line of business. So essentially the purpose of the summary of benefit and coverage is to provide individuals with that standard information. They're able to compare and they're able to make the right decisions of choosing what plan they're wanting. So as an example, we may have mammography on page 4, and I'm using that just as an example, where if they open Loveless's summary coverage benefit, or if they open up Plan B, they're going to be able to find mammography as well on page 4. So that is the intent of this particular provision. Now, originally, this provision was going to go into effect March 23rd, but HHS has delayed, and what we're looking at is September 23rd. Now, you will see that this SBC has to be 4 pages, double-sided, and it has to describe our plan, benefits, cost sharing, as well as limitations. We do have to give some cost examples based on the specific plan benefits for common medical scenarios, and then of course we have to provide the customer service phone numbers, the website, and other information on obtaining their full policy or certificate. Now, one of the challenges that we have here in New Mexico is that we have a state provision where we have to essentially include some specific benefits in our summary of benefits that we provide to all potential or existing members. So what is unfortunate about the federal requirement with the SBC is that there are some state benefits that are not included. So we have made a decision within our organization that we will continue to have our traditional summary of benefits because we do believe that it's much more detailed. However, with the SBC, it will always be available to the membership or potential members. But what we're planning on doing is actually, instead of sending out 2 almost similar documents, we will have one available on the website as well as our portals for those particular members to be able just to pull off electronically. But again, if they are wanting a hard copy, we would be providing it to them. So that's a little bit on the SBCs. On the next page, just to let you know on how we're functioning at Loveless Health Plan, you know, since the beginning of PPOC and healthcare reform, we actually started an executive steering committee. I lead it as the executive. Christina is my right-hand person that essentially leads it and kind of has been touching all products as well. But we have this executive steering committee that does consist of our corporate as well as our divisional leadership, and then of course other executives within our organization. And essentially what Christina does is she's able to come to the executive steering committee and be able to give updates on our particular work plan. But additionally, Christina also works with other work groups. We have what is called a product management committee with the other lines of business as well as business owners of different departments that meet. And that's where really the strategy occurs. They really understand what the provisions are. They come up and agree to what their recommendations are, and then that's when the executive committee makes final decisions. And a perfect example is when that particular committee really looked at the opportunity of going a little bit beyond of what the federal government was doing with preventive services. And they came to us as the Executive Steering Committee and said, we really want to go above and beyond what the federal's asking for, and let's cover everything at no out-of-pocket. So those are kinds of things that we do as an organization, and I think that should make you feel good as agents that are representing us, that we are always trying to be very proactive. And lastly, on the SBC, I will share with you that we are on target with meeting that deadline of the September deadline to make sure that we have everything available for our potential members as well as our existing members. Women's preventive services. One additional provision that came out was that we do have to cover mammogram screening, cervical cancer, prenatal care, and all of it does have to be covered with no cost sharing. Now, all of you may remember that we actually put this in place October of last year, but with the preventive services once again coming up as a new provision in 2012, there are some expanded prevention services that we will have to cover for women's health. And those are going to be contraceptive methods as well as counseling. We will have to provide some breastfeeding support, supplies, and counseling. So once again, we feel very comfortable that we will have no problem with meeting this particular provision as well. Keep in mind for the non-grandfathered plans, they are required to provide this coverage without any cost sharing. So those will have to be changed for any plan with their first plan year that begins on or after August 1st of 2012. And kind of the same information as I shared with you before, where we have our Executive Steering Committee, we also have our work group, and as I already indicated, we're on target for completing this particular provision for communication and so on. Now let's begin to look ahead. 2013, can't believe it's already the middle of May, and we're going to be entering and already having discussions of what we're going to be doing in 2013. This year we're really going to be focusing on final preparations for health insurance exchange, and unfortunately, New Mexico, as all of you are aware, we did hear that the Director of Healthcare Reform did resign. And it has kind of slowed the implementation of the exchange for New Mexico. You may all be well aware that we as a state did submit the very first grant to become an exchange. And we were very successful with that particular grant, and we got $34 million. We were entering into the second phase of a grant to the feds, and then at that time, unfortunately, the Director of Healthcare Reform did resign. Now, keep in mind with our current administration, we were one of the states that did submit a letter indicating that we did not support some of the provisions under PPACA. So I truly believe, and this is my own personal opinion, that we as a state are kind of putting the exchange on hold until the outcome of the Supreme Court hearing takes place. And then whatever outcome comes with the Supreme Court decision, we're then probably going to see the exchange move very quickly if, of course, the Supreme Court does not overturn it. And if they do, then essentially we will probably see a new initiative for the state on exchanges. Also looking forward, you'll see that the flexible spending account limits, there will be a limit to save up to $2,500 per year with their flexible spending accounts. You'll also see that there's going to be some expanded authority on bundle payments, and I talked about that earlier on how a hospital system, docs, and other type of professionals can work together to not only coordinate that care, but also coordinate that payment as well as a very positive patient outcome. You'll see that the Medicare Part A tax will go into effect in 2013, and these are, of course, for individuals that are making income greater than $200,000, for individuals or married couples that are making more than $250,000. So the tax will take place for that higher income individuals. Now, one of the areas that we also wanted to focus on with healthcare reform is the State of New Mexico 2012 legislative session. So when we really think about that particular session, there was really very little to do with healthcare reform. There was one particular bill that was passed for eye drops, and we are looking into that from a compliance point of view to make sure that we communicate that to all of you as our customers, so you'll be receiving information on all of the details of what our requirements are going to be. And then really the other thing that occurred with the State of New Mexico legislation was around a bill that one of the legislators dropped, where he wanted no discrimination to occur with all New Mexicans, that the bill was really focusing on making sure that all New Mexicans had the same type of insurance coverage. But the good news with that particular bill, because it was going to cost our state so much money for every uninsured and every New Mexican to be covered, that bill was actually delayed by sending it to a committee, and the session ended and we really didn't hear anything else thereafter. I think going forward as an insurance carrier, we just definitely want to make sure, as a rather large employer group of the state, as well as being a large insurance company, that we are very, very involved in those type of bills to make sure that we don't do something to our state that we're just not going to be able to afford. So that's really what came out of the legislation session. And of course next year will be a 60-day session, and I'm sure at that time we'll be out of the Supreme Court decision, we'll be moving forward with an exchange or maybe not an exchange, and there will be a lot more discussion going on how we're going to move forward to meet that universal coverage intent. So that concludes my portion of the presentation, and I will turn it over to Christina.
Thank you, Marlene. One thing we always want to remind everyone, and I'll show you now, is that all of the materials that we have available to you is on our website, Healthcare Reform. So when you're visiting our website, you'll notice that here up at the top, you can either go directly to this link, or here there's always this button at the top of our page that brings you to this healthcare reform site. We do keep it updated and modify our booklets. So in here you'll see that there is a booklet that we designed that will provide you, and this is printable if you would like, and it provides you just some information of the timeline. It provides information of the last 2010 going forward, of the changes that were in effect for both Medicare and, of course, the commercial line of business. And it talks about, again, all the things that Marlene spoke about today. So you can go on this website, find information, and then print it or bring it if you would like. So now we'll go ahead and open it up to the floor for any questions that anyone may have. And remember, if you need to ask a question, to remove your phone from mute by pressing *6. All right, so we have no questions from the floor. All right. Well, we do want to thank you for joining us for today's webinar. As a reminder, please do complete your survey in order for you to get your broker bonus points. We do have 2 upcoming webinars on May 24th. We'll be presenting our Healthy Steps and Worksite Wellness program with Carolina Morris, our Manager of Wellness. And then on June 1st, it'll be a 3 joint department presentation where we'll have sales, underwriting, and product going over the Loveless iPlan renewal process. And again, that's June 1st from 10 to 11. As always, you can go on to our website at lovelasshealthplan.com/webinars to view any of our upcoming webinars. Or we have a new feature that if for some reason you need to review one of these that you have missed, they're available in our library. Again, thank you to Marlene for today's presentation and for all of our guests, and we appreciate your participation.